across decades, where he has worked as lecturer, reader, professor, head of department, and medical superintendent at STM Ayurveda College, Udupi. Currently, he continues to enrich the world of Ayurveda as a professor emeritus at SDM Ayurveda College and Hospital, Udupi, while also serving society through his highly respected private practice in Udupi city. Dr. Sharma has guided several postgraduate scholars, published numerous research papers, and contributed as an expert member of Ayush and CCIM committees. A popular teacher, an accomplished surgeon, and a clinician par excellence. He is celebrated not only for his academic brilliance but also for his clinical acumen and unwavering ethical practice. In recognition of his exceptional contributions to Ayurveda education, research, and clinical service, he has been conferred with the honorary degree D. Litt, a testimony to his stature as one of the most respected voice in the field of Ayurveda. Ladies and gentlemen, it is a great privilege to welcome this living legend of Ayurveda to share his insights on Shalya Tantra perspective of liver disorders and its management. With heartfelt respect, let us all put our hands together and invite Dr. Muralidhara Sharma to the stage. Welcome, sir.
Okay.
Over to you, sir.
Okay, thank you. I think I'm audible there.
Yes, sir, you are audible, sir.
Okay. So, without wasting much time, let me start with the presentation. I think the
Yes,
screen also is visible.
yes, sir, the screen is visible, sir.
Okay. All right. Now, thank you for all that great introduction. Um, Let me start, and I am given the responsibility of dealing with the Shalyatantra perspective of liver disorder. I think there is no need to have that kind of a differentiation of Shalyatantra or Kaya Chikitsa. I would like to share the common liver disorders and my clinical experience of management of that. Of course, Dr. Nisha has spoken a lot of things like, and many of the things may seem to be repetition, but anyway, let me continue with that. Now, and I try to be very brief as such with the issue. Now, after all, liver is a very major important organ. Everyone knows it, and it has huge number of functions. The number of functions of the liver is quite huge. For the sake of convenience, we classify them into synthetic, secretory, detoxifying, storage, and excretory, as well as metabolic functions. These are the groups of the functions as such. And when the liver is damaged, any of these functions could be affected, and most of these functions are very crucial for the sustenance of the life. And hence, the liver becomes one of the vital organs of the body. And very interesting is, though in the present day situation in the society, the people say that Ayurvedic treatment is always preferred for the liver disorder. The textual description of the liver as such, as an organ, is very minimal. Only in a few contexts that you get the description of the yकृत. But most of the times we need to interpret that liver disorders from Ayurvedic point of view only from the clinical understanding. Now, anyway, the coming back to the practical situation, most of the times we need to depend upon the currently available function tests for the liver to assess, though in general we apply or we attribute the pitta dosha, rakta dosha to the liver as such, but still there are many more of the issues. I will not go into those controversial issues. Practically, we need to depend upon the current tests as investigations available to assess the liver functions as such, and the common liver function tests are assessment of the albumin to assess the synthetic function of the liver, alkaline phosphatase, it is excretory function of the liver is assessed, SGPT and SGOT, they are also the metabolic functions of the liver. Bilirubin is a detoxification function of the liver. Prothrombin time is one of the important crucial factors in the blood clotting, which maintains the vital functions of the body. These are commonly used liver function tests, but in reality there are many more of such liver function tests which could be specifically done in some specific conditions, most of the times in advanced situations. In the routine practical clinical situations, these are the usual investigations which are done, biochemical investigations which are done to assess the liver functions. In case of liver disorder assessment, at times you may need the imaging studies, and the imaging studies, USG and MRI are the crucial imaging studies useful in assessing the liver disorders. Ultimate would be the liver biopsy. Of course, there is a spelling error. Now, Without going much into that basic issues, let me directly go into the common liver disorder. Among the commonest liver disorders which we usually see in the clinical practice is the hepatitis. And the hepatitis, among them again, one of the most common which we see quite frequently is the hepatitis A. Hepatitis A is the one which has a better prognosis, and most of the times it occurs seasonally, and the incidence of that hepatitis A is also quite common in our country. And most of the times the patients of hepatitis A end up in Ayurvedic hospitals. Hepatitis A is one of the global interested condition, and at present the WHO has given some guidelines about the hepatitis A virus, and that the guideline is hepatitis A is one of the disease which is transmitted through the transoral route, fecal-oral route as such, and it's ingestion of the contaminated substance, and the hygiene of the surroundings has helped a lot in reducing the incidence of hepatitis A, and most of the times it's a self-limiting disorder, and it produces a good immunity, prolonged immunity. Very few patients would have fatal complications. Now at present there is a safe and effective vaccine also is available as such. Now the most of the times hepatitis A doesn't require more energetic treatment. All that what we do is bed rest, diet restrictions would be the most important thing. As far as the incidence is concerned, incidence of hepatitis A of course is quite prevalent in India, but hepatitis B, the next B type of the hepatitis, which is more severe and produces more serious complications, and the incidence of that in India is comparatively quite high. Of course, though China is a leading country where the number of incidence is quite high, in India the incidence is also is significant and one of the important factors. The most common causes for the hepatitis is poor sanitation, lack of safe water, and the transmission from a person who is accompanying you, that's a person to person, man to man transmission is the common thing, and sexual activity is also is possible. Earlier it was believed that the physical contact is responsible for the transmission of hepatitis B only, but now it is known that hepatitis A too can be transmitted through the physical contact. Recreational drugs like the addiction drugs, and then homosexuality, endemic travel also is considered to be one of the issues. For again, to be brief, you will not go into much of the detail. The virus producing hepatitis, they are now mainly the A, B, C, D, E, and among them our clinical interest would be mainly hepatitis A and B. Hepatitis C is more of interest in the ICUs, patients who are on dialysis, etc. They are not much commonly seen in the routine clinical practice. And hepatitis E is rarely seen, but it has some interest in the obstetric practice. Pregnant women have a high risk of that and have a high mortality. As far as hepatitis A is concerned, the clinical symptoms are usually mild fever, headache, malaise, and usually the patient will have the clinical course in 2 to 6 weeks, and the patient may have the IgM antibodies seen. Liver function tests seem to be abnormal in the initial stages. Characteristically, the transaminase level would be quite high, and once the febrile stage is over, patient would have a spontaneous resolution. The usual mechanism or treatment would be simply taking care of the diet. The rest would be enough, and to prevent the complications, you will have to ensure that the patient doesn't have any hepatotoxic diet as well as hepatotoxic substances. The usual medicines which I prescribe would be, I would always consider this as a variety of Pittaja Jwara, and my treatment would be Arogyavardhini Kumari Arsa Mrutyunjaya Rasa is the usual prescription, and even without medicines many of the conditions would improve. But more significant from the clinical point of view would be hepatitis B virus, which has a more severe outcome and has a more chronic course also, the usual the transmission through the physical activity is quite significant, and the course of the disease in hepatitis B is that initially, in the initial stage, the patient would have the HBsAg positive, and the positivity, that antibody would remain in the body for quite a long time. The virus will remain in the body for quite a long time, and this HBsAg, which is one of the important tool for investigation to confirm this hepatitis B, is seen as such. Clinical course of hepatitis B is again, these clinical symptoms are almost similar to that of hepatitis A. The only issue is they have more severe presentations. Usually the fever will be low grade. The incubation period also is relatively longer. The initial most symptoms will be vague symptoms like anorexia and pain throughout the body, fatigability. Then the patient may have jaundice. Jaundice usually takes about 2 to 3 days to be seen, but in case of fulminant conditions, the patient may have very severe jaundice. Our patient may have a very rapid development of hepatic encephalopathy, and acute hepatic failure also can occur in a few of patients of hepatitis B, though such incidence is rare. The other conditions would be pattern in, sleep pattern being changed, confusion, coma also can be the clinical presentation. Occasionally it can result in severe gastrointestinal bleeding or coagulation pathologies, where there could be multiple bleeding spots or ecchymosis presenting there. Hepatitis B, the liver guidelines by the WHO is it can produce both acute and chronic diseases, and it's the most crucial and critical issue would be when the disease is transmitted from the mother to the child during birth, as well as the transmission through the blood transfusions or blood products given in the hospital or injections where the instruments, needles are used. And from the surgical point of view, hepatitis B also creates another problem, that the chances of transmission, possibility of transmission of hepatitis B in the operating theatre or in the ward due to these sharp injuries or due to the products of blood which are transfused also are quite high. The incidence throughout the world also is quite significant. As per the data, 296 million people were having chronic hepatitis B infection in 2019. The current year, of course, 2024 data would be very close to that. And the incidence is about 1.5 million new infections every year. And related hepatitis B related death rate also is quite high, which may even result in chronic complications like cirrhosis, carcinoma, etc. The rare presentations of hepatitis B, rarely, very rarely, it may present with the pleural effusion and due to the portopulmonary syndrome, or the patient may have even diffuse intravascular coagulation. Myocardial pathologies, pericarditis also can occur rarely. Severe arthralgia, arthritic-like condition symptoms also can present. The Guillain-Barré syndrome-like symptoms also can be presented in hepatitis B occasionally. So from the clinical point of view, these are all important issues. And pancreatitis also is another of the issue. Aplastic anemia is still less common as a clinical condition seen in hepatitis B as such. The hepatitis B has to be assessed, confirmed by mainly by these immunological studies, and the immunological studies, the most common done test is HBsAg, and when the HBsAg is positive along with the anti-HBs IgM positive, then it's suggestive of an acute infection. If the patient has HBsAg positive and anti-HBs is positive but IgM is negative, then it's suggestive of a chronic infection. When the patient has HBsAg negative and anti-HBc is positive, that means the infection is resolved, and that's how it has to be assessed. So from the clinical point of view, all these are quite significant, because one of the very common complication which we develop which we see would be Patients who are asymptomatic but have HbA positive, and they again come for the Ayurvedic treatment as such. And patients who have vaccination, the ideal situation in the post-vaccination stage, usually after 2 or 3 months of vaccination, would be they would be having only anti-HBs, surface antigen positive. The anti-HBC and HBsAg would be negative. As far as the treatment protocol is concerned, in those mild, moderate cases where there is no such acute fulminant pathology, I would be considering this also as Pitta Jwara. From Ayurvedic treatment point of view, I may not make any difference between the prescription of the drug for hepatitis A and B. Only in those cases where there is a very fulminant condition, we may need the support of other treatment. Life supporting treatment also may be required as such in a few of the patients. So that is the important issue. Otherwise, I would be considered this as a Pitta Jwara, where the clinical symptoms are almost similar, like Tikshna Vega, Atisara, Nirdalpatvam, Vamihi, Kantausumkanasanam, Pakas, Svedasthajayate, Pralapaha, that sign of encephalopathy, Murcha, Laha, Madhusha. These are all the possible presentations of the Pitta Jwara, and a good number of patients can be managed successfully with the Mrityunjaya Arogyavardhini Kumariyasava given for 1 to 2 weeks. The risk factors are patients who have that acute liver failure conditions, and that acute liver failure conditions are severe complications, that end stage liver disorder conditions. They are usually graded, and that's the MELD score, end stage liver disorder score. The scores are given in form of assessment of ascites, encephalopathy signs, bilirubin level, albumin level, and prothrombin level. If any of the patients have a end stage score of more than 10, then the condition is considered to be quite critical, and they are always suggestive of a transplant evaluation. But as far as my practical clinical assessment is concerned, patients of a definite HbA positive hepatitis B, even with that MELD score of 25, with certain preconditions, like if there are no other accompanying illness like diabetes, etc., they can be managed with the sufficient dietary regulations and the same prescription which I have suggested. So there is no need to go for that kind of a advanced approach. But if the score is more than 25, of course the outcome would be very poor, and that's the one of the decisive criteria, like whether we can continue with the treatment or not. If the MELD score increases in a patient, then naturally the patient has to be referred to another center, or maybe at times the outcome would be very poor. The general guideline now throughout the global guideline is, if the patient's MELD score remains at more than 10 or more than 15, then the patient has to be suggested for the liver transplant, and that is the current guideline, which is not necessary. We can extend that guideline with the Ayurvedic treatment. Another practical problem would be patients who have asymptomatic HbA positive conditions. Patients remain either with the history of the HbA where the patient had a hepatitis, and they may remain HbA positive for quite a long time. And as far as the incidence is concerned, as per the study, recent study which is done, I have given the reference there, about 0.2 to 8% of the Indian population has, and among pregnant women, 0.6 to 11.2% among the pregnant women, HbA positive patients are there, seropositive but clinically asymptomatic. And these patients are quite troublesome in case of either obstetric practice, surgical practice, as well as in the blood bank. Blood donors, if they are positive, the chances of transmitting the virus to the recipient is quite high, and hence we have to be very careful as such. Patients who have HbA positive also are not given visa for traveling. So most of these patients, they are now, there is no definite line of treatment throughout anywhere, though in some practice they may give antiviral drugs, but antiviral drugs are not necessary. And the clinical management is always challenging. Like, of course, one of the other factors which we have to remember is some of the patients who are given vaccine, HBsAg vaccine, they may also have a hepatitis HBsAg positive. Ideally, this HBsAg positive would be duration would be for a short duration, like 1 to 2 months, which is called as antigenemia due to vaccine-induced conditions. But I have seen a few patients who may remain HBsAg positive for years together after the vaccination. And again, whether they have to be considered as the high risk or not, that's the issue. Ideally, in such conditions, we will have to go for the surface antigen studies, HBS studies, which give you a guideline like whether the patient has a risk of transmission or not. Now, in such conditions, though there are no such standard protocol of the treatment, the clinical significance are mainly as far as the sexual partners, patients with HBsAg positive, there is a possibility of transmitting this to the other sexual partner. So, some protection, physical protection during the sexual activity is to be guided. And needles and intravenous drug use, mother to child transmission, these are the risks, and blood to blood contact where the items like razors or toothbrushes are shared, there could be a transmission, and this is one of the important issues which you have to give a guideline to the patient. Risks which may result in disease conditions like chronic hepatitis or cirrhosis or liver cancer also are established, but from clinical management point of view, what I have seen is patients who are having that HBsAg positive, the diet and exercise guideline has to be given. All that possible toxic and highly spicy food contents have to be avoided. Rest has to be moderate, rest has to be advised, regular exercise has to be suggested. With that, we can prevent the complications. And the usual prescription would be Arogyavardhini and Kumari Asava. Virechana often helps in a few of the patients. And if the patient had a history of active jaundice and then had HBsAg positive, the chances of being negative within a short duration like 3 to 4 months would be very high. The patients who have been had no history of jaundice but have HBsAg positive due to certain transmission through any of the other means, the outcome would be poor. A course of Virechana helps in a significant number of patients to have the negativity as such. That's how I treat the patients with my prescriptions. Now, one more variety of hepatitis which we see, though not very commonly but occasionally, is autoimmune hepatitis. In the autoimmune hepatitis, the clinical presentation is quite vague. The patient may have jaundice much later, and usually the jaundice would be comparatively milder. Patient may have the fatigue, the discomfort in the abdomen, pruritus, myalgia, which are quite difficult to make out the diagnosis. Only when the patient has the jaundice, then we may make out the diagnosis accurately. And the jaundice is seen in only 69% of the patients and usually in the late stages. The other signs like hepatomegaly may be seen in a good number of patients, splenomegaly. The ascites may be seen in a few of the patients. So, in such conditions where the patient may not have other typical clinical presentation of a febrile onset and then developing the jaundice, the patient may have a painless onset of jaundice with vague clinical symptoms, generalized symptoms. One of the conditions which has to be ruled out is autoimmune hepatitis, and in such conditions the ANS studies would help and the outcome would be quite poor. Majority of the patients, autoimmune hepatitis, the outcome will be poor. There the only course would be corticosteroids and liver transplantation, and probably with our IDRIC treatment alone, it may not be possible to manage such patient. Now, another group of the disorders which we see in the clinical practice due to are involved in the liver is alcoholic liver disorder. Alcoholic liver disorder again can present with the acute alcoholic pathology, where even the patient may have rarely acute hepatic failure also. That acute alcoholism is a totally different issue which has to be managed in a different manner. But most common, the otherwise from the routine clinical point of view, is alcoholic liver disorders. and which can present with the mainly three forms of the presentation: alcoholic fatty liver, or which is also called as the steatosis, or alcoholic hepatitis, where the patient may have clinical symptoms like that of the hepatitis, or it could be the cirrhosis which could be presented. As such, the alcohol metabolism is normally the alcohol metabolism in smaller doses should end up in the production of the complete production of carbon dioxide, but in case of excess of alcoholism or patient who have continuously consumed alcohol, it can result in the aldehyde formation which can be hepatotoxic, and this is again classified by Sushila as Panatya, Paramala, Panajirna, which is almost similar to that of alcoholic fatty disorders, alcoholic hepatitis conditions, or even the Pana Ajirna or Pana Vibhrama is often can be considered as acute alcoholic disorder. These are the complications of alcoholic conditions. The certain facts about this alcoholic liver disorder is minimum amount of alcohol intake with the increased risk of that ALD range, that SGPT range between 40 to 80 is considered as a safe limit. But this is globally considered as a safe limit. But what I would say is there is nothing like a safe limit in case of alcohol. Even a small amount of the alcohol can be toxic and it should not be entertained. Genetics play a role in alcohol consumption and alcoholism both. Tendency for alcohol consumption also is now believed to be due to a genetic predisposition, and the possibility of alcohol toxicity also is attributed to certain genetic predisposition, and that gene is recognized as a cytochrome P450 system as such. But of course, practically to identify these genes which make you susceptible would not be possible, but this is mainly a theoretical possibility. And hepatitis C virus also is related to alcoholic liver disorders, as well as iron overload also is attributed to the alcoholic liver disorders. Obesity and dietary habits also have been considered to be responsible for that. To consider whether a patient has a alcohol induced pathology or not, the universal course, particularly those who are interested in research protocols, it has to be the audit, the alcohol use disorder assessment has to be done, and this is done mainly by having a questionnaire. That standard questionnaire would be having an inquiry about the total quantity of the alcohol and frequency of the consumption of the alcohol and the social conditions in which the alcohol is consumed, and by that the audit score is done. And usually if the score is having more than 7, they are considered as hazardous drinkers, and majority of the patients whom we see who start with the alcohol in small quantities, they develop a higher score, and the patients who have a score of more than 7, they always have a very high risk of developing alcoholic liver disorder. So patients who come with that history of alcohol consumption, it's better to have this questionnaire. I think this questionnaire is available, and every physician should have this idea of at least this questionnaire, though you may not follow rigidly that questionnaire step by step, but with that you can predict the risk of these complications and advise the patient about this. The score risk is again is indicated if the patient has a score of 8 to 12, it's having severe complications of this alcoholism over the body, and any system could be involved, and important is about the liver. Now, as far as alcoholic hepatitis is concerned, to make the diagnosis of alcoholic hepatitis, the patient who have a onset of jaundice which is persisting for more than 8 weeks, a low grade jaundice persisting for more than 8 weeks, and has a history of alcohol consumption, which is usually considered from the standard protocol is considered to be less than 40 grams per day, and that's what they say. And the aldehyde level, AST level, is less than 50, then it's considered as alcoholic hepatitis as such. And this would be the Pittaja Malatya, the clinical symptoms of Pittaja Malatya. Chronic alcoholism can present with the other clinical symptoms, and these where the patient would have systemic features like the whole body changes would be whole body, the muscles would be wasted, and the wasting of the muscles can present with the typical facial expression where the superior part of the head and the buccinator muscles they become atrophied, and hence the face looks like somewhat a bulged face. Patient may have a transient hallucinations, visual changes can occur, there could be spider nevi deformed produced, tachycardia, hypotension can occur, gynecomastia, which is again a suggestion of the chronic liver failure conditions, hepatomegaly, the signs of chronic hepatic failure like caput medusae, the tremors which are very characteristical, erythema on the palm is other features which we can see. The patient may even have ecchymosis due to the hypogonadism, that the gonads become atrophied. Jaundice also could be presented in the chronic alcoholic pathology, and alcoholic liver disorder is considered as such. From the management point of view, alcoholic disorders management, the contemporary management, the modern management will be depending upon the assessment of the severity of alcoholic hepatitis, mainly by the MALD score. If the MALD score is less than 10, then it is considered to be a relatively easier to the treatment, and the usual prescription in the modern medicine would be, of course, alcohol abstinence, supplement of nutrition. Whereas if the patient has a MALD of more than 18, then it's considered high risk conditions, and the modern treatment would be steroid protocol. But what I will be seeing is good number of such patients, they can be managed with Arogyavardhini, Kamaduga, Kumari Aswa, the Pitta Jamadati line of the treatment without steroids. And of course, the alcohol abstinence is very important. Sufficient supply of nutrition also is one of the critical issues. That's about, in brief, about the alcoholic liver disorders which we see commonly. The next type of the disorders which we see commonly now are the fatty liver conditions. Fatty liver conditions could be as a consequence of the alcoholism also. Chronic alcoholic disorders can present in the fatty liver changes. But now there is another major group of the conditions which we consider as a non-alcoholic fatty liver disorder, or usually say as a NAFLD. Now these grades are again done based upon the severity. If there is a very high alcoholic, these fatty changes, it's considered as grade 4, and it results in the liver cirrhosis. Liver fibrosis would be grade 3, where the liver would be fibrosed as such. And grade 2, if it is accompanied with the inflammation, it is also called as a non-alcoholic steatohepatitis, which is having a more severe outcome. The other simple fat deposition is a alcoholic fat liver disorders, and it's attributed to decreased mitochondrial fatty acid activity and increased fatty synthesis, as well as a deficient incorporation of triglycerides as such. Confirmation of the diagnosis of fatty liver is done by ultrasonography assessing the liver echogenicity, and the grades also can be assessed. Now these days elastography is considered to be more useful in making the diagnosis of alcoholic fatty disorders. Incidence of the alcoholic fatty disorder, non-alcoholic fatty liver disorder is increasing every year rapidly, and in India also the incidence is quite high. The fatty liver as well as alcoholic steatohepatitis, both these conditions are increasing rapidly these days, and it's considered to be one of the present severe epidemics of concern. Incidence in India is more than 6 diabetics have, and severe obese patients out of 10 would be having alcoholic, non-alcoholic fatty liver disorder. 1 out of 4 people have non-alcoholic fatty liver disorder regardless of the weight, and hence obesity and diabetes, they are considered to be one of the important triggering factors. The other triggering factors are the diet, genetic pathologies, oxidative stress, drugs, medicines, which are many of those medicines also are considered to be the important causes as such. Among those drugs which are known to have a very direct relationship with the the fatty changes, fatty liver disorders are the anti-inflammatory drugs, and isoniazid, which is used as anti-tubercular drug, valproic acid used as anti-epileptic drugs, antibiotics like erythromycin, amoxicillin, the antifungal drugs, ketoconazole, and antihistaminic drugs. These are now well known to be related to that. And alcohol, once the fatty changes have occurred, they are absolutely irreversible. All the target would be to prevent the progression. If the patient is presenting in the grade 1 and grade 2 conditions, definitely we can, with the diet and exercise, Arogyavardhini Kumari Asava, that dietary precautions are quite crucial more than any of the medicines. We can definitely postpone the possibility of progression in case of alcoholic fatty changes. But once it has reached the stage of 3 or 4, then the outcome would be poor, and the only treatment would be palliative treatment. Though I never say that there is a curative treatment, the fatty changes are not reversible, but patients' general health condition, liver function can be maintained at a sufficient, satisfactory level. Now, next up the condition which we see would be cirrhosis. Cirrhosis is an advanced pathology where the liver would be having necrosis as well as regeneration and fibrosis together. And the causes for the cirrhosis could be many. From the clinical presentation point of view, the cirrhosis is categorized into micronodular and macronodular. The macronodular cirrhosis is presented with the enlargement of the liver, whereas micronodular, the nodules will be shrunken, and hence the liver also may be shrunken in size, or at times it could be enlarged also. The causes are for the micronodular could be hepatitis, both viral as well as autoimmune, or hepatotoxin drugs substances like mushrooms, carbon tetrachloride, metabolic disorders like Wilson's disease, the drugs which are antitrypsin, or any other pharmaceutical drugs like acetaminophen, the analgesics as such, or at times it could be cryptogenic. The exact causes may not be known. Then hereditary also can be. Alcohol, of course, is one of the other causes. Macronodular is more attributed to the alcohol in case of hepatitis cirrhosis. Biliary cirrhosis due to obstruction of the bile can also be. Deposition disorders also often present with the macronodular. Indian childhood cirrhosis and surgeries where intestines are bypassed also can be resulting in cirrhosis as such. The ultimate differentiation would be only by the liver biopsy study between micro and macronodular cirrhosis. Macronodular cirrhosis, the central vein structure would be maintained, whereas micronodular, the central venous structure of the liver lobule is lost. The clinical presentation of cirrhosis is mainly one of the major complications could be portal hypertension, which can result in the varicosities, esophageal varices, hemorrhoidal veins being engorged, or even can present with the acute bleeding, which is quite critical. Hepatic encephalopathy also can be one of the presentations of the cirrhosis, which can be severe. It also can end up in hepatorenal syndromes, or there could be hematological manifestations like bleeding disorders. Cirrhosis also can be converted into hepatocellular carcinoma or cholangiocarcinoma both. Pulmonary as well as cardiac manifestations of the cirrhosis also are well known, and it can result in even in the changes in the muscular structure as such. Portal hypertension is one of the most common issue which we see, which is due to increased pressure in the portal vein, and hence the dilatation of the feeding vessels, which can result in esophageal varices as such, or it can be even of course the portal hypertension. In a patient of portal hypertension, we will have to rule out the obstructions in the proximal side like Buerger syndrome, or intrahepatic pathologies like cirrhosis, or posthepatic prehepatic conditions like venous thrombosis as such. But in all these conditions, the confirmation of the diagnosis is, and from the clinical point of view, the most important is esophageal varices to be diagnosed with the endoscopy. Of course, a direct portometry, portal vein measurement of the venous pressure also is done, but this is usually done in advanced conditions. But in the routine clinical practice, it is the gastroscopy or esophagoscopy which gives you the clear idea of esophageal varices. Esophageal varices are a potential high risk conditions which can result in severe hematemesis, and the patient may present with the presentation of hematemesis itself, severe hematemesis in case of esophageal varices, which is an acute emergency, and in that condition the immediate assessment would be absolute necessary, or at times there has to be immediate surgical intervention, like either the clipping of the vessels has to be done, which is an absolute necessary, and the best of the option there would be endoscopic assessment, and if possible clipping of the vessels to prevent the bleeding would be the most important critical issue which can save the life of the patient. The other presentations also could be the encephalopathy could be the presentations. This ascites, progressive ascites formation. Of course, ascites is one of the most common presentation of the cirrhosis conditions. Abdominal pain and fever also may be a complication of peritonitis related to the portal hypertension itself. Patient may even have blood-stained stools, hematochezia also can occur in case of that. The other clinical signs which are often seen as the signs of portal hypertension are umbilical veins getting bulged, dilated, anterior abdominal wall vessels become dilated. The flanks also may show the same features like dilated veins over that. Hemorrhoids, ascites, paraumbilical hernia also can be the presentation as such. The ascites, this portal hypertension also can result in a hyperdynamic circulatory condition which results in the bounding pulses, arterial hypotension, and pericardial murmur also could be seen as such. The chronic esophageal varices also may be the presentation around. Along with that, there could be the presentation of pallor. It may suggest about the internal bleeding, enlargement of the parotid gland due to malnutrition, dyspnea, telangiectasis, this typical hepatic failure presentation with the smell, the fetor hepaticus, which is also a sign of a hepatic encephalopathy as such. The size of the liver could be either reduced or enlarged, both these could be occurring. The hemorrhoids also can be presentation as such. The hepatic encephalopathy, now one of the most critical complication is the gastrointestinal tract bleeding produced due to the hepatic varices, where immediate intervention would be necessary, and the immediate intervention would be clipping and then support, life support by transfusions as such. Hepatic encephalopathy is another of the critical condition which requires energetic intervention, and it is categorized into the 4 grades. The grade 0 is where there are no obvious clinical signs except the patient have a known evidence of chronic hepatitis or chronic hepatic failure. Or grade 1 is a patient may have a mild confusion or altered sensations as attention could be decreased, the mental tasks would be reduced, irritability, sleep pattern could be altered. Grade 2, the patient may have a drowsiness, lethargy, or deficits of ability to mental tasks, personality changes could occur. As far as from the clinical point of view is concerned, we can manage the patient's hepatic encephalopathy at least symptomatically with the Ayurvedic drugs or many of these other conservative drugs up to grade 2. If the patient has a presentation of grade 3 and grade 4, where the patient is somnolent and is not almost totally disoriented about time and place, or the patient is in coma, in such conditions the condition would be very critical, where a life supporting treatment would be necessary, and only with Ayurvedic treatment it may not be possible to manage. And usually we would be prescribing the patients with the Smritisagar Rasa, Kamadhuga, and Saraswati in case of encephalopathy, along with the usual course of maintaining the nourishment. Degree or severity of liver disorder also can be done by the PUG classification or child-to-rod PUG class as such, as in the case of MELD score, another of the score pattern which is done, and particularly in encephalopathy, If the patient has again the assessment will be almost on the same line, assessment encephalopathy, ascites, bilirubin, albumin, and in this INR, that bleeding time also is one of the important criteria. It's almost a typical pattern of MELD, the book classification. But in case of encephalopathy, that INR would be one of that bleeding time, prothrombin time, and related to the issues is one of the important issues which predicts about the risk. If the patient has a PUG classification of more than 7, that also is suggestive of a severe condition, and there again I would be considering as a limit for Ayurvedic treatment or our treatment, conservative treatment. Patient requires more energetic treatment as such. The MELD score I think I have already referred to, and the same thing as such. The palliative prescription which I would be prescribing in such patients would be the Arogyavardhini, Purana Mundura and Kumari Asava, and particularly either in case of a portal hypertension without the bleeding, or the bleeding is managed with clipping, or it could also be in patients who have hepatic encephalopathy up to a degree of 2, along with the Smritisagarasa Sarasvarishta for the symptomatic functions of that encephalopathy. And if the patient has a moderate bleeding history, the bleeding can be reduced with the Chandrakala Rasa and Uchi Rasa to reduce the bleeding. But a patient having a massive bleeding, it has to be an intervention like a clipping as such necessary. Smritisagarasa, Kamaduga, Sarasvarishta also could be in patients of encephalopathy of grade 2 up to. Takradhara and Makrabasti would be the other options of the treatment. If the patient has a higher level, it has to be an ICU treatment which has to be done in centers where facilities are available. It's a limitation to Ayurvedic treatment as such. Another of the complications of cirrhosis, chronic hepatic failure, would be hepatorenal syndrome. In the patients of hepatorenal syndrome, there would be obvious evidence of the renal involvement, the kidney functions would be affected, and a patient having an initial hepatic pathology resulting in a renal vasoconstriction and the renal output being reduced and renal complications occurring. Even with all the effective treatment, the post-infective survival period patient would be surviving would be around 2 weeks if the patient has a history of infection and then the renal pathology has occurred. The survival period is just short as 2 weeks. If the patient has a progressive reduced GFR without the infections, history of infective pathology, then the survival period is around 3 to 6 months. And virtually no treatment, it's not only limited to Ayurvedic treatment, any of those modern medical treatment also would be able to extend the life of the patient, or maybe very high levels of treatment like life supporting treatment would be required. And hence, once a patient has a hepatorenal syndrome, it's better to leave the patient to the sophisticated centers where the direct intervention is possible, or ultimate treatment of liver transplant could be the other options. The cirrhosis also can present with other evidences like hypersplenism, where enlarged spleen itself would be a cause for the hemolysis, and hence the patient would have hemodynamic effects like, and in such conditions a splenectomy also may be necessary, though it's not the treatment of choice. Patients of cirrhosis also tend to develop iron deficiency, bleeding tendencies, vitamin deficiencies they to occur. Supplementing of these also may be necessary. Another of the common most presentation and would be a simple ascites. Of course, a patient of ascites with cirrhosis may have all the other complications also, but as far as the simple patients have ascites where otherwise the patient is stable, as a symptomatic management of the ascites, I would be always prescribing Gomudra with Triphala Churna, Arogyavardhini, Punaramundu and Kumari Asava. Though it cannot cure the ascites like conditions, the patient can be managed satisfactorily for a quite a long period. The expected life period can be enhanced, complications can be reduced as such with these prescriptions as such. Patients who have ascites, they need not be drained, or that regular therapeutic aspiration is not necessary unless it produces a severe respiratory distress. Repeated tapping of the fluid uh, increases the risk of complications, the infective complications, as well as the systemic effects of loss of protein also would be very high. The patients would have hypoalbuminemia, and then you may require to supplement the albumin also, which is always a vicious cycle, and hence the tapping should be postponed to the level as fast rate as possible. Only when the patient has a severe respiratory distress, to manage the respiratory distress, you may require a tapping. A chronic hepatic failure can present with huge different presentations, systemic conditions, and hence it is essential to identify these conditions as such, with all these signs which is starting from the head to the foot, the usual textbook description. And any of these complications have to be assessed, and many times you may have to have a management which is specific to these complications. So I think with the consideration of saving the time, I would not go much into the detail of this. We will be just limiting to that. One of the other condition is the acute liver failure. Again, acute liver failure could be produced due to various conditions. It's not only due to any of those conditions which you have discussed earlier. Hepatitis could be a cause. Drugs also could be a cause. Toxic substance, the patient may have either homicidal or suicidal, or at times it could be the iatrogenic drugs which can produce a acute liver failure. So definition of acute hepatic failure is as considered as a INR being more than 1.5, neurological dysfunction with the hepatic encephalopathy, no prior evidence of liver disorder, and disease course is less than 26 weeks. That's considered as a acute hepatic failure. And acute hepatic failure causes could be in about 70 to 80%, it could be the drugs, and the systemic disorders, metabolic disorders like Wilson's disease, shock, congestive cardiac failure, metastasis from the liver pathology. Viral conditions also could be the poison, could be the other causes as such. Clinical manifestations again would be, there could be either signs of hepatic encephalopathy due to involvement of the brain, kidney and renal glands being involved result in hepatorenal syndrome. Systemic pathology is presenting with the systemic inflammatory response, where the patient would have a severe immunosuppression, susceptibility to the infective pathologies. Cardiac pathology, where the patient may have a hyperdynamic heart conditions, and even myocardial injury could occur. Pancreatitis also could be presented. Lungs may have acute lung injury. Bone marrow also may have a suppression as well, and that would be the clinical presentation as such. Course treatment from Ayurvedic point of view, I would not suggest any possible curative treatment in case of acute hepatic failure. Modern drugs also would be having a very limitation, and the selection of the drug would be depending upon the cause as such. The common group of the drugs used are the specific antidotes in case of the toxic substances, particularly patient with the poisons as such, they would be the right treatment. And the osmotic diuretics to reduce the possibility of hepatorenal syndrome, barbiturates to reduce the possibility of the complications of brain injury like seizures. These are the usual drugs, and none of these would be really a rather ultimate curative treatment. Only in those conditions where a toxin could be detoxified, the patient may survive. Otherwise, the complications would be high, and hence to define a specific line of treatment in acute hepatic failure would not be easy as such. Then another of the conditions which we may see occasionally is the Wilson's disease, which is due to an abnormality of the copper metabolism in the body, where the patient may have a chronic hepatitis like conditions which also can result in cirrhosis. The typical evidence clinically would be the Fletcher's ring, that reddish ring around the eyes and usually seen in younger age. Patient presenting with the extrapyramidal symptoms. It's a presentation with the tremors and dystonia along with the hepatic failure conditions. Seizures also could be presented as a sign of Wilson's disease. In case of Wilson's disease, from Ayurvedic management point of view, again, I don't say that there will be any drug which can cure the condition, but in my experience, which I have seen, is Bhringarajasava with Arogyavardhini helps in reducing the copper levels, and palliative management is possible. In many of the conditions, it could be seen somewhat better than penicillamine as such to reduce the copper storage in the body. The other symptomatic treatment which are usually given is the levodopa drugs like to reduce that extrapyramidal symptoms, anti-epileptic ulcers. Then the next important part is about the real Shalya related conditions, the liver abscesses. Liver abscesses is mainly the the Yakut is Vidradi, among the Andhra Vidradi, Sushruta has mentioned like the Yakrut as a site of Andhra Vidradi, and the clinical symptoms are considered as Shwasa and Trishna are considered as the signs of the Andhra Vidradi involving the Yakrut. From the present day's point of view, mainly these abscesses are categorized into either the abscess of infective origin. Among the infective origin, it's mainly either pyogenic or the amoebic. Then iatrogenic abscess, when abdomen is handled surgically, any surgical handling may result in the transmission of the infection into the liver, and hence it may be presenting with an abscess, or the abscess also could be a result of the malignant pathologies. Malignant abscess could occur. When we say infectious abscess, it could be the either protozoal origin or bacterial origin, where the infection could be transmitted from another abdominal organ like appendicitis, diverticulitis, which may have perforated. It can result in as such. From the incidence point of view, among the clinical conditions which we see in India, amoebic abscess form around 75% of the patients. Pyogenic abscess form about 15% of the patients. Comparatively, in advanced countries, Western countries, amoebic abscess is very lesser, like 10% in USA, whereas pyogenic abscess are more common compared to that. So, from our clinical routine point of view, almost 3/4 of the liver abscess patients are amoebic abscess as such. Among the global incidence of amoebic abscess, India is one of the zones where the incidence of the amoebic abscess is very high as such. I think life cycle of entamoeba histolytica is a well-known phenomena where in the enucleated cyst would be developed in the liver and it forms the abscess as such. I will not go into the detailed pathology as such. The clinical presentation, the symptoms would be fever is seen in a large number of patients, in 81.4% of the patients. Weight loss, the next common. Nausea and vomiting, anorexia, and these numbers which you see on the screen are the incidence, percentage incidence as such. And the right upper quadrant pain, hepatomegaly is the other signs. Jaundice is generally not seen in majority of the patients, only in 25% of the patients jaundice is seen, and it's true in case of any of the abscess like rigors, diarrhea and pleurisy-like symptoms. They are very few and rarely seen in many of the patients of hepatic abscess. The main is the right upper quadrant pain, fever, and the gastrointestinal tract symptoms like nausea and vomiting are the major criteria. Confirmation of the diagnosis of the hepatic abscess is done by ultrasonography. Is always better to make the diagnosis, or MRI scan also could be the MRI scan or ultrasonography could be the obvious choices of making the diagnosis. Ultrasonography is always much better and more efficient. Differentiation between pyogenic and amoebic abscess also is possible with the ultrasonography. A pyogenic abscess would have, or even MRI can give you that clear idea. A pyogenic abscess would have a thick surrounding border, whereas a typical amoebic abscess would have some infiltrating border. The borders are not clear. Contents of the amoebic abscess would be having high echogenicity, irregular densities, whereas pyogenic, the pus would be somewhat clear. As far as the general guideline, the routine clinical guideline is concerned, in case of the amoebic abscess, if the size is less than 6 centimeter and there is no evidence of rupture, and its symptoms are usually the conservative treatment is preferred. That is the general idea. If the size is more than 6 centimeters, then it has to be a aspiration, where a USG guided aspiration is necessary, and USG guided aspiration also is necessary if the patient doesn't respond to the usual treatment in 72 hours. If the patient USG guided aspiration is not successful, then you may have to go for a percutaneous drainage, where you may have to make an incision. Laparotomy also could be needed in case of an abscess if it has rupture or there are evidences of peritonitis. So primary surgical approach in case of abscess would be based upon its size and other complications. Treatment as such protocol in the modern drugs would be metronidazole or paramomazine. But Ayurvedic treatment, patients who have a hepatic, particularly amoebic abscess and diameter is less than 6 centimeter, can be effectively managed with Tifalagubula, Anandavirava and Varnadikwata, and a good number of patients can be managed successfully. But the same criteria, if the size is more than 6 centimeter, aspiration is essential, and aspiration either would be ultrasonography or percutaneous drainage would be the other issues. The again, the universal criteria for the assessment these pyogenic abscess would be, in case of the pyogenic abscess, the issue would be when the patient has a high fever like condition, total leukocyte count would be raised. In that condition, if the patient has a pyogenic abscess and if the abscess has ruptured, then immediately surgical drainage is necessary. If the pyogenic abscess is produced as a result of a previous surgical complication, that's an iatrogenic condition, then to a surgical resection, surgical drainage would be necessary, open surgery would be necessary. Even in case of the pyogenic abscess, the modern criteria would be if it is less than 3 centimeters, antibiotic therapy and conservative treatment is preferred. If it is between 3 to 5 centimeters, then a percutaneous drainage is done if there is a single locule as such. If there are multiple, then it is better to open. This is the usual protocol, and of course the standard protocol in the modern treatment would be antibiotic. Of course, in a pyogenic abscess, the incidence is comparatively lesser in our situation, and the antibiotic would be necessary. I don't think that it would be possible to manage only with the Ayurvedic treatment protocol. Next group of the conditions which are somewhat of significance would be the liver cysts. Among the liver cysts, simple cysts are often accidentally found out during some assessment, ultrasonography, which are asymptomatic and which are harmless, and they do not really produce any symptoms. Multiple cysts are polycystic liver disorders which could be genetic, and in such conditions virtually there is no question of any curative treatment. Only when the polycystic conditions are huge and then because of the mass effect the liver function is affected, a surgical aspiration may be necessary. But otherwise, majority of the conditions there is no need of any specific treatment. Parasitic, among them the hydatid cyst is one of the conditions which can be managed to a certain extent from the clinical point of view, and cystic tumors are the other conditions. Identification of the simple cyst is done by simple either ultrasonography or by the MRI scan, and the general standard protocol is the size has to be assessed by follow-up studies regularly, and if the size doesn't change in 2 to 3 years, there is no need of any intervention further. Polycystic liver disorder, as I told you, there is no definite protocol of the treatment, but it can be identified by the MRI or ultrasonography. There is virtually no question of any specific curative management. All that you will do is protect the hepatic function so that it doesn't get deteriorated. Hydatid cyst is transmitted through the oral route due to consumption of improperly cooked flesh of animals, and the hydatid cyst is having a cystic the development in the liver with distinct three layers: the ectocyst, endocyst, and membrane, the inner membrane as such, which is seen in as hydatid cyst conditions, and it often can result in further daughter cyst formation either in the peritoneum or in other areas. The treatment protocol would be mainly the albendazole is the usual treatment given, and the hydatid cyst also is graded by ultrasonography based upon the WHO criteria. I think we will not go much into that issue. They are categorized as unilocular and multivascular conditions. Treatment protocol is mainly the albendazole is the usual drug of choice and usually given for a short duration. Of course, even from our routine clinical point of view, that would be one of the better treatment protocol. But I would say the better would be, along with this albendazole short course, usually given for a short duration of 1 to 6 months. We may add on with the Mrityunjaya Arogyavardhini Kumari Asava to facilitate the recovery and reduce the complications. And the last part of the discussion would be liver tumors. Among them, benign liver tumors are either the hemangiomas and adenomas and focal nodules, which are of lesser consequence, and they can be differentiated by either ultrasonography or maybe the MRI scan, or if necessary by the needle biopsy as such, where there is no question of any specific management. All that would be wait and watch and rule out the possibility of a malignant change. But more of concern would be the hepatocellular carcinoma, which is rapidly increasing throughout the globe. The increase in the incidence of hepatocellular carcinoma is quite high, and it is considered to be one of the major concerns of the future in case of oncological practice. And the most important cause would be a cirrhosis, which is converting into hepatocellular carcinoma. Chronic liver disorders, any of the chronic liver disorder, particularly virus hepatitis B and C, is resulting in cirrhosis and developing into hepatocellular carcinoma is one of the important issues. A non-cirrhotic pathway for the hepatocellular carcinoma is related to the genes and alpha toxins which are present in the food asset are also attributed to be the cause of the hepatocellular carcinoma. The risk factors, among them the cirrhosis, hepatitis, viral hepatitis, alcohol, obesity, and anabolic steroid consumption are the major risks as such. Exposure to alpha toxin is the other issue. The clinical presentation of hepatocellular carcinoma is also quite vague. The course is quite relatively slower, and it presents with the typical signs of jaundice, splenomegaly. All the signs of hepatic failure like hepatic encephalopathy can also occur. Pain is usually uncommon but often seen. Confirmation of the diagnosis can be done by MRI or USG to identify these features. And alpha fetoprotein is one of the usual tool to make the diagnosis of hepatic carcinoma. Risk prediction also is can be done with the alpha fetoprotein as a tumor marker. Patients who have the alpha fetoprotein levels being higher, they are considered to be having a high level or risk of chance of hepatic cellular carcinoma, and a level of more than 400 is considered to be a possibility of development of that hepatocellular carcinoma. Outcome of hepatocellular carcinoma is quite poor. The survival period is just 18.4% with all the treatment. The options of the treatment is if the patient has a single tumor and otherwise surgical feasibility is there, surgical resection is considered to be one of the better option. Liver transplantation is the other issue, and the palliative treatment is the ablative therapies or palliative bridging treatment would be the other protocols. Cholangiocarcinoma is the other diagnosed condition where the tumor develops within the biliary system and widespread lesions occur. Prognosis is extremely poor. In that condition, patient may have early jaundice and signs of hepatic failure occur very commonly. And jaundice is the most common. Painless jaundice, which is rapid, and high levels of jaundice is the other signs. All features of obstructive jaundice would occur in such conditions. Weight loss and abdominal pain would be the other features. The last part of our discussion would be the liver transplant, which is considered to be the ultimate treatment for majority of these liver disorders. The general guideline for the suggestion of transplant would be, if the patient has a MALD score of more than 10, the patient is considered to be a potential candidate for the liver transplantation. And MALD score, I think I have already described about that. Then the exception for this would be hepatocellular carcinoma, which is considered to be always a choice of the liver transplant as such. But incidence of liver transplantation is now increasing rapidly throughout the globe. Even in India, the number is increasing as such, and the centers where the liver transplantation facilities also are available. Last part is about the 10 herbs which are considered to be which are proved to be some hepatoprotective, having action of potential liver as such. And from different research protocols, it is considered Guduchi, Pippali, Purnama, etc. are considered to be hepatoprotective. At the same time, there are lots of negative propaganda about these plant drugs also. There are many people who claim, many so-called hepatologists who also claim that many of these drugs are hepatotoxic. So there is a issue of these controversies which we have to face with, and maybe to conclude, the last point would be the liver disorders require thorough clinical assessment, and Ayurvedic treatment protocols can be game changers when used judiciously. With this, let me conclude. Thank you. If there are any questions, I will try to answer, or then we will conclude. I think already we have crossed the time limit, so thank you.
Thank you so much, sir. That was really a wonderful presentation, sir. Now we'll go ahead to the question and answer session. Delegates, I request you to post your questions and doubts in the chat box.
Okay, there are no questions. I think it is better to conclude now.
Yes, sir. I'll ask once more, sir. Delegates, if you have any doubts or questions, you can post your questions in the chat box, or you can raise your hands to ask the question directly to the speaker. So there is a question, sir.
Okay, there are no questions.
The question, sir, may I read it out, sir?
Hmm.
The question is, any medicine for alcoholism in alcoholic fatty liver, sir?
Alcoholism, to prevent alcohol. I think, see, I don't suggest any drug to prevent alcohol. The anti-abuse drugs. It's not a choice of the things. Of course, they are available. And many of the people would recommend many Ayurvedic asavas also. Shrikanda asava is a claim to be one of the drugs which are used like. But I don't suggest in any of my patients, I don't suggest any medical treatment for alcoholism or alcohol prevention. Even in the contemporary medicine, that anti-abuse like drugs also are failure. It's important that the patient has to have a confidence that he can stop the alcohol. And the better is the counseling. The patient has to understand the issue, and the patient has to stop on its own willpower. That's as far as the abstinence, alcohol abstinence is concerned. As far as the drugs to treat the patient of alcoholism, like when the patient develops the symptoms of or complications of alcohol, there are two issues. One, the acute symptoms developing due to alcohol withdrawal, where the patient may have tremors, confusion, loss of sleep, etc. In such conditions, I would always prefer to use our Medhya Dravyas, Nidradhanaka Dravyas like Sarasvarishta, Smritisagara as a symptomatic treatment. It's not a treatment for alcohol. This is just to support the patient to withdraw from the alcohol in such conditions. Then the other issue is about the hepatic complications or the complications which have developed due to alcoholism, like the chronic hepatic liver complications, alcohol liver disorder. I think I have already discussed somewhat in brief, maybe, though not in very detail. The medical prescription which I would always prefer would be Arogyavardhini Kumari Asava, which would be helping in reducing the hepatic complications. Then the other part would be the like nourishment, providing the nourishment in as an alternative. For providing the nourishment, it's mainly about the diet which has to be done. Regular exercise is the other issue. Is about the treatment protocol. I think that's all about the interventions which you can do in case of the alcoholism like conditions.
Thank you so much. Moving on to next question, sir. Any nasya for hepatitis?
Any?
Nasya. Nasya.
Of course, there are many claims of that. I don't use that in my practice. That's it. There are many people who claim, and lots of articles also are presented about the use of nasya in conditions. Of course, text also describes about the nasya, but in my practice, I don't use that. It's not essential to have that.
Yes, sir. Thank you, sir. Moving on to the next question, sir. Arogyavardhini Vadi is a rasa aushadhi. So, how many days can we give continuously in liver?
There is absolutely no harm. There is absolutely no need to worry about the rasa aushadhis. This is a unnecessary phobia about the rasa aushadhis. It can be given as long as necessary to the patient. I have treated patients with the Arogyavardhini for years together. It's not only Arogyavardhini, many rasa aushadhis. So phobia about rasa aushadhi is not really necessary. Unfortunately, most of the times it's only the Ayurvedic students and Ayurvedic doctors who are having more fear about the rasa aushadhis. I think that's a very brief answer.
Yes.
Okay.
Thank you, sir.
Right.
For the next question, sir. Sir, is it safe to prescribe Asava and Arishta in alcoholic liver disease, as these are also alcoholic preparations, sir?
See, it's to consider or to group Asava and Arishta as alcoholic conditions, alcohol as such. Now, though in our text it's among the Madhya and Madhya varieties it's mentioned, addiction forming alcohol and the alcoholic medicines, they have to be categorized separately. When we use it as a medicine and which is prepared properly, the drugs where the fermentation process is done with the herbal drugs as such, the alcohol generated is of a very low quantity and it's not going to harm in any way. But of course, we have to be aware of the current trends many times, where instead of using this conventional fermentation process, Asavarishtas are prepared with the many addition of some alcohol. They have to be recognized as such. So you have to be, when you prescribe Ayurvedic drugs, you have to be somewhat confident about the method of preparation. That conventional method of preparation, when they are bypassed, then alcohol can be toxic. Then the other part, like certain of the drugs which are not really samhitoktas, there are many yogas now which are prepared from many maybe unethical preparations, which are claimed to be which are often misused as an alternative for alcohol. Certain such practices do exist in the society. I am not denying that part. We have to be aware of that. But academically prepared and well specified, indicated Asavarishta can be safely given in liver disorder, and it cannot be having or equated with the alcohol as such.
Thank you, sir. On to the question, sir. What duration can Shilajit can be given? Does it cause infertility, sir?
I think this is an unrelated question. Shilajit producing infertility is not at all known as such. I don't know. I have not come across that. As far as the duration of Shilajitu is concerned, as per the text, the Shilajitu Rasayana in Samhita, it's around that 48 days, that's the maximum duration in the dosage which is mentioned in the Samhitas for the Rasayana, where the yoga quantity is quite high. Whereas practically, generally, we will not administer at that high dose. It is usually the lower doses which are prescribed, usually it's around 500 milligram. And with that dose, the duration, there is no specificity about the duration, the issue is about the indications. Whether there is an indication for prolonged administration or not. If there is a indication, specific clinical indication for administration for a longer period, Shilajit can be given for a longer period. And as far as the infertility related to Shilajit, I don't know. Rather, Shilajit also, Shilajit is often claimed to be one of the drugs which are prescribed in the treatment of infertility, though I don't prescribe that in routine conditions. Okay. Right.
Yes. Thank you so much. I think that's all for the question,
Okay,
sir.
fine. Right.
Sir,
So
shall we wrap the session, sir? Yes, sir. Thank you so much, sir, for sharing your
okay.
expertise and patiently answering all the doubts. We appreciate your time and knowledge in enlightening us today, sir. Thank you so much, sir.
Okay, thank you.
Dear, I hope you found today's session informative. I trust that the insights shared will prove to be a valuable addition to your clinical practice. If you have any further questions or need clarifications on any point, please don't hesitate to reach out.